All right. Thank you so much for everybody for joining us tonight. We have our final webinar of our winter webinar series. We have Dr. Alejandra Garza, who'll be presenting tonight on preparing your horse for summer riding. So we have an exciting webinar left ahead of us. We would ask if you have any questions. You can notice just at the bottom of your screen, there's a chat box. You can enter it in the chat box for if you have any questions throughout. Otherwise, we'll be answering questions at the end of the webinar. I'm going to also add in the email address. You can email if you're keeping track, if you've been attending on each of the webinars and you'd like to get your certificate, as well as every time you're on a webinar, you are entered in to a contest to win a first aid kit. So be sure to send your email along to the email that I will enter in the chat box at the bottom there. I'm going to pass it along to Dr. Alejandra when you're ready there.
Hi guys, how are you? Thanks for joining. Let me just share my screen now. Okay, let me know if you can see it.
You're good there, Dr. Ali. We can see your screen.
Perfect. Alrighty, well, thank you again for joining me. So today we're gonna be going over a few topics. Pretty much preparing your horse for summer riding is what we want to discuss. I know there's been the other 3 webinars that I'm going to be referring to because they do have a lot of information that I won't be covering here today. So if you haven't watched them, please go ahead and get back to them. So my name is Alejandra Garza. I've been with McKee-Pownall for 3 years now, and I am based at the Caledon location. So if you haven't seen each other, come and say hi. So to begin with, so we're going to be covering the here, let me just move this out of my site. Yeah. We're going to be covering some topics, right? And here it's pretty much, like show season. So you got to get on top of, vaccinations, your Coggins, nutrition and supplements, and also the performance exam. So we're going to be covering a full performance exam. What do we do on a performance exam? And also, what do you have to look for? So I'm gonna remind you, that not all is musculoskeletal. A lot of people think that when we say, oh, let's do this preseason exam is because we want to, make sure that there's no lameness. So not all is lameness. When we do a performance exam, and I'm gonna go over it in detail, we check every single system of the horse, right? So it's a good opportunity to remind you that it's not just that we're looking for. So so where do we start? We want to begin either if you're a client of us, right, or or you have this new horse that we haven't seen. I think it's important that we getting to know your horse if we have not, and if it's one of our regular clients. There's one thing that you gotta remember. Every year your horse's age, right? So every year we might be encountering a different thing. So not because we know him pretty well the year before, that means that this year is gonna be the same. So I think it's really important that we keep, keep that in our mind when we look at the horse. So the main reason for doing a preseason exam or a performance exam is because, like I said, we want to get to know you and your horse, and what are your guys' needs. Remember, you both are a team, so you kind of want to get this get the best out of the season. And for that, I mean, you kind of want to have him check, make sure that everything is okay. And it's not that you want to wait for him to come up with a lameness, or if you notice that there's some deficit here and there, even if it's weight, and we'll talk about that, we gotta just get on top of that. So the main reason for the evaluation is that we can come up with a plan A, B, or C. Not because we see him once, that means that visit we're gonna do everything, right? We gotta revise and see where we're at, if we're gonna run some blood work, if we gotta check some, like reference values to make sure that, like based on his age, everything's fine. And then based on that, decide what type of maintenance we're going to do, or diagnostics. And I'll get to that. So the other thing, it's paperwork, right? You got to get on top of where you're showing. If you're going to be needing a Coggins test, I know last year some of the show places didn't decide to run a Coggins, but like I think this is going to depend on what level you're showing, or even if you're just going to go across a state on a province on a trail ride. So that's important that you have your Coggins. Also vaccine certificates, right? If you're going to go to a show ring, you got to have proof of your flu rhino vaccine. So it's important that we get those up to date, and you know exactly what the requirements are going to be from the place that you're going to be going. Passport, same thing. If you're an FEI horse and we got to get those stamped, that's something that we're going to be looking to do and go over. Okay, so the performance exam. So pretty much what we want to do is we want to put the pieces of the puzzle together. That being said, it's mentioning see that we already commented on. So I want to just make a clarification here, because the exam may vary among practitioners, and here's where like we are all different veterinarians, right? We're under the same like type of training. We have practice standards, but you got to think that if it's the first time that I'm going to see this horse, I might just like want to touch him everywhere and poke and probe here, because I want to know his weight, like I want to listen to his lungs. I want to check everything. If this is the 10th time that I see him and I know him pretty well, I might not do like a full flexion, kind of like a previous what I call it like a mini pre-purchase exam, because it's I know him and I know what's normal for him. I know that it might have a bit of a scar tissue here and there. I've worked with him before, so I know that I have to pay attention to those things. But if that's not the case, then we have to spend a bit more time, and we got to book accordingly to that, right? Like if it's your first time visit, we might be wanting to do like an hour and a half exam full, and then with suggested radiographs and stuff, and even if we're going to be treating, but this might vary in between veterinarians. So what are we going to get out of this history? We need to know where he's at, where he's been, and just a simple example here is I bought this horse last year, and they told me that he has had his hocks done like 2 years ago, and he hasn't had them done. So we might be looking at like, okay, it's nice to have that piece of history, because if we flex him and he's a bit positive, that means that he might be due to get his injections. Or we can look at shoeing, or like anything that might be important like as part of the examination. So we do want to know his previous athletic performance history, right? We want to know what he was doing. Where do you want to take him? What's your plan for him and you for the season? If you have any particular concerns, right? If you heard that in the past, this or last year he got a tear here and there, or he stumped or he's been like tripping, that's not normal. So it's important that if you notice anything from the year before to this one, that you communicate everything, because then that will give us a better like idea of the time that we're going to be building, if we're going to add on like a specific radiographs, or even if it's a horse that went for the winter to Florida, or like went show somewhere else, and he was seen by other veterinarians south. We need to know if he got recent injections, all that information we got to be aware of, because we don't want to be missing those parts of the information when we go back and we look at him previous like to this season. All right, and then here's when I jump into like that maintenance work. If he had it, if he didn't, if we know that he is a 21-year-old or even a 16-year-old with degenerative joint disease, let's say that we did x-rays last year and he does have some hock arthritis, well, we kind of want to repeat, because sometimes when joints are fusing, we want to know if we're going to even be able to go into the joint, right? So if we suggest that, we can also sometimes when we inject and we can feel if there's resistance in a joint, and we might make some notes about, we can come back, revise this, and then maybe do like based on the quality of the synovial fluid that we get, if we get anything back from the joint. Sometimes we won't get, especially like in really narrow low motion joints, when they already have some degenerative joint disease, or like I said, previous injuries relating to anything, like, oh, he tripped, he got a wound and there's a scar tissue, so that we can just come up with a better plan for that visit and the rest of the season. Okay, so that's the puzzle. Okay, here, so the preseason performance exam, I want to make that emphasis again. It's not only musculoskeletal. I started talking there because that's where everybody's going, like, oh, my horse had injections last year. And, we get that question a lot. Maybe he needs maintenance, maybe he doesn't, maybe he needs maintenance somewhere else. But you got to remember that every time we do exam on your horse, we tend to listen to the heart, right? Like, especially if we're going to do sedation and things like that, we need to listen to the heart. So here's where it comes the the cardiovascular examination. So when we listen to the heart, we're not checking for like, oh, the rhythm, right? We want to make sure that, there's no murmurs, that compared to last year, his heart doesn't sound different, right? That he does have a regular rhythm and it's not an elevated heart rate when he's resting, that he's not, like, it's normally, like, sometimes we'll have horses that have AB blocks, and that's that they mean that they drop a beat in between, like 3 or 4. It can be regular or irregular. But I think listening to their heart, it tells us a lot, because and then I'm getting into the respiratory part of it, because even if you don't think so, the respiratory exam, right? Any like issues related with the respiratory tract comes up with, like, it's a good part of the horses that get affected, is the second number cause of decreased athletic performance, right? Like when they're not doing good, they're not thriving. It might not be that they're lameness, it might be that they have asthma, that they have some heart issues. They say a murmur, or rarely, like we'll find horses with AFib, but that can be detected with the stethoscope, right? So we always listen to the heart, we listen to the lungs, and like I said, like the respiratory system it comes up to be the second one to cause more problems that affects the athletic performance of the horse. So then here, for respiratory, right, as part of the examination, we always auscultate the lungs, the trachea. We want to make sure, like, and that's why we always, like, and this is the part where we, like, if you see us like putting the stethoscope and then we get quiet, it's because we want to get the most out of it. Sometimes we don't listen to the questions, and then we just ask you to just wait a minute until we listen, because it's really hard to listen when there's like noise around, if we're in a barn, right? Or if there's like a driveway nearby, or the dog barking. So we try to listen to the trachea and lungs, make sure that we keep up things. But I'll show you later that sometimes, even if we don't listen things and we think that they sound normal, when we do testings, it can look bad, right? So I think it's important to keep that in mind. So then asthma, I want to just I've been in Canada for 3 years now, and this is a place that I've seen more asthma. So it's been a good learning curve for me, because I've never seen that much. Like, I've practiced in California before, and yeah, you got the fires, and like we see more like skin reactions, not that much asthma when I was there. But here, I think with the beautiful seasons that we have and how horses just get adjusted, or they out with round bales, like they will get more exposed to the dust and particles, and they will be more sensitive or hypersensitive to them, if I mean. And then allergies. I mean, and when I say allergies, I think it's really important that we think that when the horse is manifesting signs of allergies, like in his skin, I don't know what's happening inside, right? So then that's when we come up with okay, is it good to do allergy testing? If it's always like seasonal, what can we do for him? to make him more comfortable? Do we want to just modify and wet the hay, and like, or get a steamer? It depends on your needs. So we can just go about that. So then we do want to also check the gastrointestinal, and by mean here is not only us filter the abdomen and say, oh, it sounds good, like the barbaric are normal, like the gut sounds sound good. We can also, like, if we take the time, we listen if it sounds more watery, and we ask about the poop, right? Like, and if we don't ask about the poop, you tell us, like, just please relay all that information. We do have horses that have inflammatory bowel disease, so, and they're silent, right? They're silent, so they can be squaring a bit of water after, like they pass normal manure, they have leaky gut. So we want to know, because if you're here and we're seeing him and you have that concern, we can pull blood, and we just want to make sure that their proteins are fine, that there's no elevated enzymes, that everything it's okay, especially those older horses that have been on anti-inflammatories for a while. We always want to get like that information. So you're going to be like our best friend here, trying to figure out, and then we can just start there, and then just come up with a plan A, B, or C, like I mentioned before. So things that we do, right? We, besides blood work and just like listening to the guts, we look at their body condition score, right? So if your horse, it's showing all season, or you take him to like trail rides, you want to know, we want to make sure that he has enough muscle, right? Like that he's nutrition, it's okay, that he has body condition score, it's adequate, that he's not lacking muscle in the neck or in the back. It's not only like, oh, because of the saddle feeding, like, and you're going to add more pads. It's because we want to know and make sure that okay, why is are his ribs like palpable? Like, if he had a winter off, he was eating all day hay, like, what's going on? Where is he not getting his minerals? We can also run like a vitamin E and selenium. We can talk about the supplements that he's been on, and maybe they're good supplements, but that doesn't mean that those are the ones that he needs. So we talk about all of that, and that is part of the exam. And if we don't mention it in the consultation, right, like when you're there with us, it might be easy to be like, oh yeah, let's just focus on the musculoskeletal. But it's not only that, right? Like, we usually weight tape them, we get an idea, we feel them, we record their body condition score, and then this is when we're gonna get into the other part, which is ulcers, right? If it's your horse that has been, and I'm not going to do a full webinar, Dr. Gomez, he's done previous presentation on it, so I suggest that you go back in onto our website and look for it. It's pretty complete, and it goes up, talks about the different classifications for equine gastric ulcers disease. But here's when you tell us, like, if it's girthy, and not because it's girthy that means that he's going to have ulcers. There's a big correlation. It could also be coming from pain in the back. But I think like, this is the moment to tell us, like, okay, so now that we're here, I think he's been girthy. He's been pinching his ears when I'm like brushing him. Every time that I get near the sternum, or when I go like right by the thorax, like at the end where my God, I already forgot the name. Yeah, right by the girth, right? So there, if it's sensitive, just tell us, right? We might be doing some pressure points to see, if it's sensitive, if they can flex their back, if they can, like, if they do have good movement, like lateral flexion. If we put pressure on the, like the ribs and the hind end muscles, we try to make them move so that they can tell us if they're restricted, if they don't want to elevate their back, if they don't want to like elevate their sacroiliac region or thoracolumbar spine. So we can just get that idea during the exam as well. So then we come into the musculoskeletal, right? So here it's just a good example of, like, it's not only the limbs and the hooves that we're looking at everything. Even we look at the eyes, right? Like, we look at the eyes, we make sure that they're visual. It's part of our physical examination to take a look, make sure that they're no squinting, all of that. So then we are going to jump onto the age-related findings. Of course, it's not the same if you have a 5-year-old that you just started on training, right? Even if it's a warm blood, or if it's your 3-year-old quarter horse that is already like barrel racing. I think we need to just frame it to, you know, every particular horse. So we'll say age related findings, and I want to say wear and tear, right? Let's say that your horse is a 16-year-old, 20, in that range, and we know that there's been some changes. Last year he got injections. We want to know what else is going on. We might suggest to pull some blood work, because you see, like, there's risk of doing joints injections, right? Like it's as simple as if you cut yourself and, you know, bacteria tracks in, right? Even if we prep sterilely and we do it pretty well, and we use sterile gloves, sterile medications, there's always a risk. So we always want to minimize those risks when we go into a joint, even if it's going to be a blocking of the joint, not treatment per se. We do want to know exactly, right, how is he systemically, right? Because if you think about using steroids, we're not going to just go and, like, it's framed to go to the joint, right? Aim to go in there, but it does get some, you know, like systemically, right? So we have seen some beneficial from horses that get, you know, joint injections, and then that residual, you know, absorbed medication can make them feel pretty good for their asthma, that it's subclinical. So it's important that we get in the habit of, like, yeah, let's run blood work. You know, it's important that the older they get, we want to know if there's something going on, even if they look like systemically healthy. You do want to know and catch it up early, rather than later. So here for blood work, I say we might suggest a CBC. And this is going to tell us, you know, like if he's anemic, if his platelets are low, we might run a TP, which that will be included on the McKee-Pownall, which is the total proteins. So for the McKee-Pownall, we're going to look at all of the muscle enzymes. We're going to check the proteins. If they're, you know, if your horse is underweight, if his proteins are low, you know, if he's sensitive to, you know, like the GI palpation, we don't know if there's something going on inside him, right? He might not show hives because he's not sensitive to anything, like, you know, like to show it on his skin, but he might have some reaction. You know, there might be some inflammatory process going on and within. So then based on that, we can suggest some panels and discuss. So then we jump into the ACTH, right? And then we want to know, like, oh yeah, well, if your horse is cushingoid, yeah, the older they get, yeah, but you know, sometimes I've seen horses that are like 22 years old, 24, and their ACTH is normal, and God, they do look cushingoid. Like there's, yeah, I mean, their hair is like long, curly, and not because their ACTH and the panel is normal. You know, like we won't put them on the medication. We do see benefits on putting them on, and that's something that we'll have to discuss, because there's always, you know, like risks of, you know, like, okay, do we want to do this? Yeah, I mean, we want to, because it looks like cushingoid, even though the blood is not doing it. So we can do a small trial and see, we can start at half a pill, like half of the dose, and see if we can build up that dose until we see a regulation, even if in the blood it's not abnormal. And then the metabolic part of it, right? So this is a really hard conversation sometimes, and I just want to point it out, because I know horses are coming back from winter and they were like, you know, like, just, you know, chilling and not doing the regular exercise. And here I will say, you know, there's higher risk of not knowing if it's an easy keeper. Let us know, because I don't want to put steroids on a horse that might have insulin dysregulation, and then I can just trigger laminitis, right? So that's why we push for doing tests. If it's a healthy horse that he sheds normally, and he's, you know, like in his 10 years old, I won't be too worried. But in this case, like if he's obese, meaning like his body condition score, I can barely feel his ribs, you know, and I look at his feet, and he does have rings on his feet, right? Like, and I'm like, okay, well, let's check his pulses, and that might be a bit elevated. He might be negative to the hoof testers, right? But you know, like, we want to know. We will maybe suggest, if we see changes in the hoofs, we might suggest to do radiographs. We call these like a trimming rats. So we take 2 radiographs, like front and back, like front to back and side lateral to the inside of the foot, so that we can get an idea what's his balance, you know, like if he's hoof pattern axis is normal. If he is, like broken back, broken forward, and we got to do adjustments. Maybe you're used to have him like he's barefoot, but maybe he has requirements for a specific type of shoeing, and we might do suggestions based on that. So also, and I'm telling you, like, all of this, it can be discussed on that exam. It's not only like, oh yeah, let's see him walk, trot back and forward, oh yeah, flex. It's not that. This is your opportunity to come and just give us as much information as you have. Bring your questions and concerns, and we can just go over things, because like I said, I rather get all the information. If you feed him only a little bit of food and he doesn't lose weight, even if he's doing exercise like constantly, then we're like, let's look into you, right? Because you might be at risk of like these beautiful green pastures that are in Canada, right? And then we see these horses foundering, like during the spring, summer time when they get exposed. Even if they don't look metabolical, like obese, we might have some insulin resistance, right? You don't have to be obese to have insulin resistance. So I want to point that out. So every once in a while, as they age, and they're easy keepers, please let us know, and we can run this panel to make sure. And this panel just includes your insulin by itself, or we can pair it up as their age with ACTH and glucose, so that we can get more information. Okay, that was a lot of talking on that. Okay, so now we're going to jump into, I might go back to that in a minute, but we'll jump into the musculoskeletal exam. So we do perform an static exam. So, and Dr. Viviana Hernandez did a beautiful presentation on how do we do, how do we evaluate lameness. So I'm just going to go over some things here quickly. And why do we do the static examination, right? So this is what's going to tell us a lot about joints, age-related issues, conformational, like if there's some thickness here and there, and we write down everything. We want to know so that next year when we see him, like, oh, this got worse, like maybe we should be looking into doing radiographs. So yeah, pretty much that. So the static examination includes palpation, right? So you might see us, like doing after your physical exam, and think about all the things that we already talk systemically. Yeah, we're going to start, like palpating the limbs. We check their feet. Some of us, we put the hoof testers in the beginning or in the end. And then we check for passive flexion. So once we palpate, then we ask for the limbs, and then we palpate tendons, ligaments. We flex their knees. We check their shoulders. We check range of motion, right? We want to make sure that they're able to move. As they age, some of them might get decreased range of motion on their fetlocks or high motion joints, like coffin fetlock, knees, the tibio tarsal joint on the back, and that. And we're also going to look at that neck and back range of motion, right? It depends on the sports that you do. Like, let's say that it's a dressage horse, it's a quarter horse that it's like doing like just barrel racer, and he's just like leaning to the one side, or it's it's a high speed, or like it's more of a time training that can have wear and tear in different areas based on the discipline that you're doing. So we will be doing like for neck range of motion, and we recommend for you to do that too at home. We can do cookie stretches. It's really important for the horses to get like do a carrot stretch. If it's metabolic, don't give him carrots. We'll get into that. It's not normal to feed that much sugar, especially at horses that are at risk. So range of motion, just like we can ask them to go around up and down, so that we can evaluate if they're sensitive. You might see us palpating their cervical facets. We can scan their cervical facets too, if you have any concerns. So if your horse trips, it's not normal that your horse trips, right? It's not normal. So you have to let us know. I don't think it's because the shoe is too long. I mean, unless it's like super toe long. But those are things that as they age, especially like those warm bloods, you want to make sure that they don't have like any neck arthritis if they're being, like flexing their necks, or like holding a position on the neck that might cause strain in some areas, and then develop osteoarthritis as well. So let's not forget about the neck. That's important too. We can do radiographs of the neck. We could do ultrasound of the neck as well. There's some other modalities like bone scan that we can get refair. But yeah, I mean, it's important that we keep that in mind, right? Especially if it's like you know, like a mild lameness on the front and back, and we're like, we don't know what's going on. So for the back, I kind of like went over it already. So we might ask them like put pressure on the sternum, and that's something that you can also do back home. You kind of want to know how flexible he is, right? So you just put pressure on the sternum, and if they're elevated and just look at you like, okay, it's fine. But if you put pressure and then they just look at you and they pinch their ears, just like, what are you doing? You know, like there might be some pain, right? Either from the dorsal spinal processes, there are, you know, like maybe there's some remodeling and he doesn't want to like flex and extend his back because it hurts. And we can also see that when they're moving, like when we go into the dynamic part of examination, we can see if they're bouncing their back or if they're just like really stiff. So that's important, right? And also here, I just want to make this note. What is normal for this horse in particular is not the same what is normal for a 2-year-old, a 3-year-old, dressage, quarter horse, barrel racer. You know, it's not the same as for your 22-year-old friend that, you know, you just do a bit of a trail ride because, you know, you want to have fun with him, but and he still, it's, you know, like it's serviceably sound, if we may say. So I think this is important that we discuss that. And what are your goals? What are your goals for your horse and age related, you know, issue? Okay, so then next here for the dynamic exam. How am I doing on time? Okay, good. Halfway there. So for the dynamic examination, we do evaluate them at the walk, right? So we've spent, you know, like 20 minutes doing a static examination, palpating here and there, making notes, getting history from you. And then we're gonna have you or our technician, if they're with us, walk him in a straight line. And then you might see us walking like next to them because we want to see. So when we go next to the horse as we walk, we want to see what's the range of motion as they're moving, right? So we call that cranial and caudal phase of a stride to, you know, make it fancy. But we do want to know if it's short, right? Because there shouldn't be like, if it's a 3-year-old and he's like choppy gait and he's a quarter horse, and I'm like, oh, do you have navicular syndrome, right? Like, should we be looking at taking radiographs? Are you sore when we put the hoof testers there? Or yeah, you know, like when they get older and they have hawk arthritis, yeah, they might be landing on their hind toes and they might be really short and the hinds as well. So those are things that we have to, you know, like look. So we walk next to them, and then, you know, like I video everything because I like to sit down, and when I make my notes, you know, like I look at the videos in a slow motion. So and then I just keep track of it, you know, because I enjoy doing sports medicine a lot, same as some internal medicine. And you already noticed that I make big points on respiratory and metabolic because that can end the career of your horse, right? So we want to pinpoint that as well. So we walk, and then we will see them at the straight line trot. So we'll have our tech, will be standing right behind, and we want to see them go on a straight line trot. And then we'll just come to the side, and then we'll see them trot, you know, just so that we see if they're dragging their hind toes, right? Like if they're bringing that left hind or right hind inwards or outwards, like on the line. So we want to know what they're doing. If they're bringing the whole limb out, all of that we want to know. Yeah, it takes time, and you know, maybe one evaluation might not be enough, and we have to do some blocking and things like that, but we want to know as much as possible so that we can get reference for whenever he comes back and he gets seen after we do phase A of the treatment. So then lunging both directions, right? We want to see them, we won't canter them on a straight line. Sorry, that's a mistake. That's going to be a hard one to do with my tech, but trot definitely. And then lunging both directions. We'll see them at the walk first. We have them walk, and then we ask them to go on the trot. If they, you know, want to buck and kick and whatever, and they get back to their rhythm, it's fine. But it's not normal that a horse starts at the trot and he's just bucking and not wanting to go on, getting his neck out or stumbling with one hand. Like that is not normal. Like they should just go on a trot, you know, like normal trot, especially if they're used to trot, right? Like if it's a 3-year-old that hasn't done anything and he's a warm blood, yeah, we might not get him to there, but we want, you know, according to where his age is, like I said, and what training he has had, we want to see them move and then see cadence and the rhythm, right? So then for the trot, then we transition to canter. and then we transition to trot. We want to see them go through those transitions. Sometimes we'll see horses that are weak behind. So here I have a video that a horse that is moving pretty well, actually. If you're coming from afar, sometimes we'll ask you like, bring your saddle, right? Because sometimes we might not see anything. We might not see anything when he's not being ridden, but when we put the saddle on and, you know, like there's something going on. So, yeah, so we launch him left and right. Here you see like he looks a bit heavier on the heavier side. But if he's moving okay, it's fine, right? We can just talk about the weight and how to get them to the adequate weight. You don't want super heavy horses either, right? Because that brings or more instability and wear and tear. They have to learn to use their core. So pinpointing that, bring your saddle if you are from, you know, out of our area. We do have our indoor arena. That's the one that I display here. So this is at the Caledon location. So we can see them right there. Okay, so then, like I said, Dr. Viviana Hernandez did a beautiful presentation about lameness. So I'm just going to go over, you know, like this quickly. So we can start with blocking. When we say, okay, I have these concerns, he's lame on the right front, left hind, maybe it's really subtle. And you'll see me and some other of our practitioners using a gait analysis app. I like it a lot. I've been, you know, like I've been using it for the last 6 months, a bit over that, and I just get in the habit now of putting it. It doesn't take too long. We evaluate the horses on the straight line, and then we get a good baseline, right? So this complements our exam, so we're the primary examiner. I just want to make that important because this is still, you know, like it's a really good app. It's really well developed, but in the end, it's us. We are more objective. You know, like we're palpating, we're seeing, we're flexing, and this is just recording, right? So we have all of the pieces of information, and the app will give us a bit of more information on, you know, like how is this horse tracking based on their artificial intelligence that they use. So ultrasound, you know, like we might suggest to do an ultrasound, and sometimes we might do x-rays and ultrasound on the same visit. And I'm just going to make a clear example here. So let's say that we block to the foot, right? We block to the foot. We do a baxial nerve, and from the pastern down, right? He gets better. Like if he's, you know, like we grade their lameness 1 to 5, and a 3 out of 5 is something that you will see on a straight line trot. So here is where we go, okay, yeah, he's a 3 out of 5. We gotta, you know, if it's visible on the straight line trot, it's blockable, right? So let's just block him. So we block, he blocks, and then we localize it from the fetlock down, pastern region down. So then I'm like, okay, yeah, why don't we shoot, you know, I see some changes on the shoeing, on the not the shoeing, sorry, the balance of the foot. I think it's a little bit broken back or forward, you know, like we can suggest to do radiographs. We can do the foot radiographs. I always recommend doing the contralateral limb, because you might have a really, like, you know, like broken back conformation in one and the other one broken forward or normal. They're going to be compensating a lot on the foot that it's more normal, right? So then you're going to get more wear and tear on that one, and you got to think about that. So if we suggest the radiographs, it's mainly because of that. So we have Dr. Gomez here modeling an x-ray on a horse, and then here, you know, ultrasounding. This is from a thorax that we are doing, but so when we block it, we don't see anything on the radiograph. Remember that there's also soft tissues, and there's a bunch of soft tissues down there in that region that we need to rule out. Because let's say that, you know, like he blocks, we do radiographs, I don't see anything. And then let's say, oh yeah, well, you know, we assume that he's due for coffin joint injections. Yeah, well, he might be due, but he does have a tear on the deep digital flexor tendon. So I'm going to make you feel better with, you know, a treatment, and he does have a tear. And that tear is not going to get better with that, you know, injection. He might feel slightly bit better, but he might be there. So we got to rule out some things before we go so comfy and start, you know, like doing treatments that might, you know, counterbalance the rest of, or like the primary issue, if that's the case. We might suggest, you know, either or both. And then, you know, if it's something that we cannot figure out, remember that we can also send the horses for MRI, right? We do have a standing MRI at our practice, so that can be done. And if it's something, you'll see Dr. Kate Robinson here doing veterinary spinal manipulation therapy. So that's our chiro. So we can have her. I work with this amazing veterinarians, and we share cases all the time, right? I'm like, hey, I wasn't able to figure this out because I think there's something else going on. Would you mind feeling like this neck, and like we can refer them to them once we've done the examination and we rule out all those things, right? We just try to like play and get the whole team, working on the one horse in particular. And then here, like I said, like this is like an example of what the gait analysis looks like. It just gives you on a scale, like in this case, he's right front push of asymmetry. And he looked okay on the hind. So and then if we block them, we see them after, and we keep recording and adding. The good thing is, like at the farm, if you bring them over, we have good service. If you don't have good service, it's going to be hard to get this uploaded right away and get the answers. All right, so that was a lot of chatting about lameness, but here these are like pretty much therapies that we can do, right? So we can talk about what do we want to put them on. Maybe your horse is doing fantastic and he's a 5-year-old, and we're not like, we didn't find anything, he's moving good, but he's going to be used the whole season, so we want to give his body what he needs, right? Like good nutrition. Remember that cartilage does not regenerate, right? So we got to preserve it and take care of it. So what we do is we use different type of hyaluronic acid IV. We can also use glucosaminoglycans. They've been proven to help the collagen matrix, and just bring more nutrients for the joint per se. So we can do a cruciatic one, and then sometimes we'll see great results just with that, right? Especially on young horses, or it might be like a good supplement. We have different brands here in Canada, so we can discuss that on that visit as well, or we can also do some IV products too. And then if we elect to do anti-inflammatories, right? Let's say let's do a course of anti-inflammatories because you have concerns and you don't want to use steroids in a joint. We don't have to use steroids, right? If the joint, it's a joint that just started and there's no advanced degenerative joint disease, we can use orthobiologics, and we'll get into that. I'm just going to mention them, but like that's something that we can discuss, and this is based on your horse. Like there's no recipe for all the horses. Every horse has different needs, and then we're just going to discuss this based on that. So some horses we might do like, hey, he tripped, something happened, let's put him on bute for 5 days, but then it's not getting better. So what are we going to do? Okay, we have to come back and we have to revise. If there's something going on, maybe he did fracture, it's not a foot abscess, maybe he does have a fracture and we have to do radiographs. So all of that, and we just got to remember that if you are showing, you need to know your withdrawals, right? Like we cannot eject the horse that he can show tomorrow. There's protocols that we do, and we will be discussing those with you. So you need to know, like if you are pretty familiar, like with your show calendar, then we can have that discussion when you come to us, and we need to know the dates exactly so that we can make the best decision for this particular case, right? And also the withdrawals for your Banamine, your Pravequine. You cannot like like in the past people will be like combining, oh, let's give him Dex and like the dexamethasone, and then also put him on some bute. We don't mix them, right? Like the risk of giving different drugs and affecting the GI is not good. So it's better to just come up with a plan and then just decide what we're gonna do together. And then there's some others biphosphonates that can be used, especially for horses that like this is a drug that has been used in humans for a long time, and it's actually made for osteoporosis. So it just regulates the osteoclastic activity, and it does take some of the pain away. So we like it. It's not my first, I don't use it on young horses personally. So if it's an older horse that had changes, navicular bone changes, or like we know have some degenerative joint disease here and there, and like or bad arthritis, we might use it to see if that takes the pain away as well, or if it's a a lesion that there's no way back from that, but we want to keep him comfortable because there's bone pain, we might try to use it, right? So we can discuss those two. And then, like I mentioned, the regenerative medicine that we use. There's a bunch of different therapies that we can use. So we have IRAP, we have PRP, we have stem cells, we have prostride, right? So we can't and this is really important that we discuss, because not all the horses are candidates for this. Okay, so if it's a horse that has really bad degenerative joint disease, we're late, right? Like, it might help us if we've tried everything, but you gotta think that not because we use a regenerative medicine therapy, it means that it's going to regenerate the cartilage of your horse, right? So we use it in early stages to try to preserve and ease off the anti-inflammatory. There's a bunch of research going on, but it's not magic, right? It's not magic, and I want to just make that like very, very clear. And we might discuss, and it might not be the best option for your horse based on what it is. But if it's a young horse that is competing and has very mild synovitis, and like, why use steroids if we can use prostride, for example, like, which is one of the top medications that I really like it, or IRAP as well. Alrighty, so I'm gonna wrap up that. That's gonna be for the musculoskeletal. Like I said, if you want to know more about that, just go into Dr. Viviana Hernandez webinar. And then now we're gonna jump into this, and that probably is gonna give us the next 10 minutes that we have to finish the webinar. So asthma. I said that I was going to go back to it because, yeah, it's pretty prevalent here. Okay, so what do we do? What do we do with the horse that he coughed once at the beginning of the, the riding? Like, I started walking him and he coughed a couple times, and then he got some like swallowing, and I noticed that he was like swallowing, and then he got better, or he coughs like a couple of times once he starts, when we get going, or he stops and then he coughs. That's not normal, right? Like, you just don't get up in the morning and start coughing, right? Like, unless you have something else going on. I mean, as we get older, we might, right? But because we have to clear out our trachea. But that's the one thing that we gotta think, right? Like, so horses are, if you think about how big is their trachea and then how big are their lungs, if allergens get into the system, right? Well, the mucociliary apparatus of the trachea is going to try to catch up everything, and same in the deeper in the lungs. Like, everything's going to get encapsulated. It's going to try to get pulled out, right? So this is where we get creative with different techniques, because maybe he's not lame, but he's not wanting to go. Okay, and then he coughs once, but or maybe he's just like, oh, he's lazy, she doesn't want to move, and then this is when we go into like, let's listen to him, right? Let's just make sure that we're listening to him, right? We need to be quiet. We need to try to get like a quiet space. Listen to the lungs. We listen to the whole lung field. We check the trachea. You might see us do a tracheal rattle. We move the trachea. Sometimes we brush kind of like the trachea, and if we do that, if they're irritated, they might start gagging or coughing, right? If there's some irritation. So if we have those concerns, right, then we say, okay, let's do a rebreathing exam. And what is a rebreathing exam? Pretty much we're kind of like, because we cannot tell your horse to hold your breath, kind of like when you go to the doctor and they want to auscultate your lungs, they just tell us like, oh, inhale, exhale, keep it, hold it, like horses won't do that for us. Sometimes they just hold their breath when we're examining. So that's the one thing that we want to do. So this is a rebreathing exam. So yeah, it looks like we're suffocating your horse. We are a little bit. It's not for too long of a period of time, right? We leave them some air to go into the back. That's a short bag. I just grabbed that photo from the internet, but this bag has to be a bit longer. And what we want is like for them to build more CO2, so then they get deeper breaths, right? So then when they do that, it's going to be for me easier to listen like deeper. When he goes like full deep breath, I might hear like a little, like sibilance or, crackles or wheezes. I might hear that, like that. I won't hear if I don't have the bag, right? And even if we do this, sometimes they sound like they're good, but their still performance is not great, right? So then we discuss, okay, he did cough once, he's doing this. Do we scope him? Yeah, we can scope him, right? We can see if there's any irritation up in the trachea, on the larynx, like, and on the entrance to the airway, right? We have the arytenoids, we have the epiglottis. Sometimes they will have some issues, like dorsal displacement of the salt palate, and then they swallow a lot and they cough to try to get it in normal position. They might have a cyst. So looking into that respiratory region, it's great. We see it with the camera. We take photos. We can go down the trachea, and if everything looks normal in the upper airway endoscopy, we can still look down halfway to the trachea, and it shouldn't be normal to have a lot of mucoid. Like, it should not be normal. Like, I'm just going to show you these 2 samples of a mare that we got to work a little bit over a year ago. So this sample that you're seeing here, it's from a transtracheal wash. So a transtracheal wash, we can either do it 2 ways, right? We can do it through, it's called transtracheal because we go through the trachea. So we can put a needle through the trachea, and we make a hole. We feed like a little cannula, and then we pass a tube, right? So we go through the trachea, and then we collect. So this is what we collected out of that mare that sounded completely normal in her lungs, and like nothing sounded abnormal in her trachea. So, but she was still like low performance. So this is what we collect. It looks like milk. That is not normal, right? So we were so glad that we did the transtracheal wash on that mare. The other way that you can do it, I didn't mention it, but it's through the scope. So we might just pass the scope, and then through the scope, when we have the little canal to pass the tube, we'll go there and then collect the sample through that little chamber. So this is what we got out of, this was pulling on the bottom part of our trachea, right? They do have a thoracic inlet, so it goes there and it pouch a bit. So that's the perfect spot to get it. And then sometimes that's why we listen to the trachea, right? Because we want to hear if there's like, like that noise in that region. So we got all this sample because we do put some saline, right? We put saline and then we flush it back to try to collect as much. So maybe the volume, it's, like diluted. So imagine how wide it was, and this is what the lungs are giving back, right? It's not from the upper, it's coming all the way. And then it's just the lungs are like, get out, right? So they're trying to pull it in there. Horses get their heads down. Sometimes we'll have some like white mucoid, like, and it might be, clear, but if you see some white, it's nasal discharge, just let us know, because that could be coming from the sinus, or also the lower respiratory airway. So then we ended up doing that horse with, we did a BAL. So here we have the syringes of the lavage. So here that you see this foam, it's called surfactant. So that's when we know we got a really good sample, because this is actually inside the alveoli. So we bronchi, we get this surfactant. That's what helps the bronchioles get open, distended. So if we get that back, it's not the easiest thing to see, because we pass the tube all the way down, we lodge it in the thing. The horses are sedated. It sounds like it's pretty invasive, but it's actually just a little bit. But we do it under sedation. It's pretty safe. We just put saline, like water, sterile water, and then we get it back, right? So if you see here, I have like a good amount of syringes, 3 syringes with probably like 120 mLs total, and then we got our sample here. Sorry, I'm just gonna drink a bit of water for a second. And you see there's a surfactant here. So then we send these to the lab, and then the lab will send us back a report of what type of cells there were, right? So in this case, this horse, what we did is we put her on treatment, right? We treated for asthma, and she got better. Like within the next month, she was already like doing better, moving better. And then once she was treated with steroids, and we did everything through like a mask, not systemically. I did not treat her systemically. Sometimes we don't have to go and load them with steroids. There's other options. We can do steroids in the lungs and then just treat the thing locally, right? Also, there's a lot of management. We change the hay, we steam it, like we just go over different things that we can do to make this horse in particular do feel better. So that's out there. So that's the bronchoalveolar lavage here, and this is from the transtracheal wash, and this is a reading exam. Okay, and then just to finish up with this, so if your horse, it's an easy keeper. I already talked about this. I'm not gonna go over again. It's that easy that we pull, like some blood, and then we check his serum, just basal insulin, right? It should not be higher than the normal, like even, like it should not be higher even if he hasn't been fasted, right? If he's under 600s, it's 100 to 300 number reference value. If it's, like 500, yeah, it shouldn't be like that, right? Like it's not normal. And if he does have rings on his feet, like, and he's always been like sensitive to where he stands on the ground, like all those things we can discuss. And this is part of the performance examination, right? So better to point that out before he gets, like, or she gets this bout of laminitis that we'll see, right? Like this horse has laminitis. He wasn't an easy keeper, but he was a silent insulin resistant horse, and just dive into a good amount of grass, and that's all he needed. And he never was sensitive to the testers when we palpated him, and in the beginning, like he tricked us. We thought he was colicky. So like in every case is different. And then then you're like, okay, why are you not showing me? So he was more ill systemically rather than just like showing signs of inflammation in his feet. And then by the time he showed them, it was just like rotation level. It's been ongoing, right, doing better, but he's always at risk. Like he's always going to be at risk because he's an insulin resistant horse, and we have to manage men differently. All right, so I think this is pretty much everything that we go over on a performance exam. It's not only the musculoskeletal part of it, it's pretty much everything. So here I'm just gonna say thank you guys. Oh my god, it's 7:59, so that's good. And I just want to say thank you for your time, and if you have any questions, I'm happy to entertain them.
Thanks, Dr. Ali. I did receive a question. It was asking, what does IRAP and PRP stand for, and how do they work?
Oh, so I represent interleukin receptor antagonist program. So protein, sorry. So what I do, it's like, so interleukin-1, it's pro-inflammatory, right? So we want to antagonize that interleukin so that we can modulate the inflammatory response within a joint. So if you think about a joint having, like an insult, so I didn't put that photo, but when you have the joint has synovial villi, that's the capsule, right? So that, helps produce the hyaluronic acid and keeps everything on homeostasis, like beautiful, healthy hyaluronic acid within the joint. And when that gets disturbed, like say that he's strained a bit more, and then that gets angry, so then, you're going to have an inflammatory response within the joint. So when IRAP has been on the system for quite a while, it works pretty well. It's a bit different than what I mentioned, like ProStride, right, which is the same pretty much with other add-on anti-inflammatories mediators. It does help with modulating the pro-inflammatory response from all the cytokines and interleukins, like that get exposed in the joint when there's an inflammatory process going on. And then the plasma rich platelet that we use a lot for healing purposes. It does have a lot of like anti-inflammatory mediators, and like it helps the joint regulate like the inflammatory process, and ease off that crazy response that sometimes we might get from the synovial villi.
Thank you for explaining that.
Any other questions?
Can you see the chat box there too, Ali, or do you want me to read it?
Yeah, I got it.
Okay.
So yeah, it's just thank you. You're welcome. What are your thoughts on nebulizer and asthmatic horses? How could you nebulize by use maintenance, preventive, or asthmatic horses? Okay, so that's a really good question. Thank you, Don. We can start as easy as getting a just a puffer, right? So in the early stages of like once we get the diagnosis, right? Once we get the diagnosis, what I like to do, let's say, okay, I did a BAL, right? Or sometimes we won't have the budget to do the BAL, but he's having all the systemic manifestations of asthma. He's coughing, or he has like he's a heavy horse, and we want to treat it in the lung. So we can use there was a device that is not available anymore. It used to be, it's called a servo. So it was a device that we used to put directly in the nose. It was pretty good, a bit expensive, but it's ciclesonide. So ciclesonide, it's a steroid that we use to treat asthma in humans too, right? So we just modify the amount of human puffers that we can use for the horse. And if we get those inhalers, right, we can do it through the one puffer. Let me remember the name. Oh my God, I'll get back on me the name of the mask. And then if we have the big one, that nebulizer is good because it already comes with a chamber to attach the puffers, right? So we can nebulize them. And if they're pretty critical, like if it's a horse that is really asthmatic and we haven't done any allergy testing or whatever, right, and he's still getting exposed and getting those bouts of asthma, I do highly recommend getting it, because in the end, you get a more potentialized response if you nebulize them, plus you give them the steroids through that same chamber. I think it's a really, if your horse has been diagnosed, I highly recommend getting the nebulizer. Do we have another? Aerohippus. Yeah, thank you, Dr. Gomez. That's the one. So it just goes on the one nostril, you attach it, and then you wait for them to inhale, and then they goes in. So that's the name. But yeah, I do highly recommend them. Also maintenance, guys, like I just want to pinpoint that maintenance is the key for asthma, especially after we have spent the time on doing the treatment with the steroids. Like we might combine steroids with some bronchodilators. We can do bronchodilators systemically. A lot of people is familiar with ventipulmin, respipulmin. It's not a standard of care to keep them on. I don't know if you've ever been on bronchodilators. I have, because I had asthma at some point, not asthma, pneumonia, and it's awful. Like it's the way you feel your system feels, it's like you get shaky. So it's not great to keep them on that long. So it's better if we treat it directly in the lungs. Yeah, you can use saline. That's good. You can use saline. It's all of that you put in that saline, just by pure saline, is gonna help clear everything out. So that's gonna give some moisture into the lungs, and that they do that in humans a lot. So we can do that just with saline. That's good to do. Just make sure that the saline is clean, right? Like it's a clean bottle. We always say that. Try to keep everything that goes in super clean, with clean needles and syringes, so that it doesn't track anything down the lungs.
Well,
Any more questions?
I'll maybe just give a little closing spiel here while we're waiting, if there's just any more questions. So if anyone is tracking their attendance to try to get the certificate from us, they can email. I put it just in the chat box there. It's just marketing@mpequine.com, as well as if you want to get your name in for the draw for the first aid kit, please send an email to that as well. This is our last of our winter webinar series. If anyone has any topics that they'd like to learn more about, or in general, feel free just to, again, send us an email and let us know. We really want to make these sessions about what you guys would like to learn, so all of your insight is really appreciated.
Thank you, everyone. We have one more message. Thank you.
Yeah. All right. Well, I think that we don't have any more questions. So thank you so much again, Dr. Ali, and everyone for attending. It's been great, and I hope you all are getting your horses ready for summertime. Thank you so much, Dr. Ali.
Thank you. Have a good night, everyone.